Acute hypoxemic respiratory failure is one of the most common reasons patients end up in the ICU. For years, many of us have assumed that high-flow nasal oxygen improves survival compared with standard oxygen therapy, but a new, large randomized trial published in the New England Journal of Medicine challenges that assumption. In the next few minutes, we'll break down this new oxygen therapy trial, look at a randomized study examining whether ICU physical restraints actually prevent delirium, and finish with a teaching discussion on small airways disease in COPD and why oscillometry may soon change how we assess early disease. These are 3 recent studies with direct implications for pulmonary and critical care practice. Welcome to This Week in Pulmonary and Critical Care Medicine. Each week, we break down several recently published studies in pulmonary and critical care medicine and focus on what they mean for real-world clinical practice. The goal is simple: help busy clinicians stay current without having to read dozens of papers every week. Let's start with the oxygen therapy trial. Acute hypoxemic respiratory failure remains one of the most common causes of ICU admission worldwide. Oxygen therapy is the first step in management, and over the past decade, high-flow nasal oxygen has become widely used in this setting. High-flow therapy delivers heated, humidified oxygen at high flow rates, often exceeding 50 liters per minute. This approach allows delivery of higher and more stable FiO2 levels, generates a small degree of positive airway pressure, washes out dead space, and generally improves patient comfort compared with traditional oxygen devices. Because of these physiologic advantages, many clinicians have assumed that high-flow oxygen should translate into better clinical outcomes. Earlier trials even suggested a possible survival benefit. To clarify this question, investigators conducted a large, multi-center, randomized clinical trial comparing high-flow oxygen with standard oxygen therapy in patients with acute hypoxemic respiratory failure. The study enrolled more than 1,100 patients across 42 ICUs in France. Eligible patients had acute hypoxemic respiratory failure characterized by tachypnea, pulmonary infiltrates on imaging, and a PaO2 to FiO2 ratio of 200 or less. Participants were randomly assigned to receive either high-flow nasal oxygen or conventional oxygen therapy delivered through a non-rebreather mask. The primary outcome was death from any cause within 28 days. The results were striking in their simplicity. Mortality at 28 days was 14.6% in both groups. There was essentially no difference between high-flow oxygen and standard oxygen therapy. However, when the investigators examined secondary outcomes, an important signal appeared. The need for endotracheal intubation occurred less frequently in the high-flow group. About 42% of patients receiving high-flow oxygen required intubation, compared with roughly 48% in the standard oxygen group. That represents an absolute reduction of about 6 percentage points. So while high-flow oxygen did not improve survival, it did appear to modestly reduce the likelihood of intubation. Serious adverse events were uncommon in both groups, although a slightly higher number occurred in the high-flow group during spontaneous breathing episodes. How should clinicians interpret these findings? The key message is that high-flow oxygen likely does not confer a mortality benefit in acute hypoxemic respiratory failure. At the same time, reducing intubation remains clinically meaningful. Avoiding invasive ventilation can decrease complications related to sedation, ventilator-associated pneumonia, and ICU length of stay. But the trial also reminds us of an important principle in critical care medicine. Interventions that improve short-term physiology or delay intubation do not always translate into improved survival. For now, high-flow oxygen remains an appropriate first-line therapy for many patients with acute hypoxemic respiratory failure. The benefit appears to lie primarily in reducing intubation rather than improving mortality. Physical restraints are commonly used in the ICU, particularly for patients receiving mechanical ventilation. The reasoning seems intuitive. If a patient becomes agitated, they may remove their endotracheal tube, central lines, or other critical devices. Restraints are often applied as a preventive measure to avoid these events. Yet surprisingly, there has been very little randomized evidence supporting this practice. A recent multi-center randomized trial attempted to address this gap by comparing two different strategies for restraint use in ventilated ICU patients. The trial enrolled 405 patients who had recently started invasive mechanical ventilation. Patients were randomized either to a restrictive strategy, where wrist restraints were avoided unless severe agitation developed, or to a liberal strategy, in which restraints were applied routinely and reassessed daily. The investigators focused on an outcome that reflects two of the most important neurologic complications of critical illness: delirium and coma. The primary endpoint was the number of days alive without delirium or coma during the first 14 days after randomization. When the results were analyzed, the difference between strategies was minimal. Patients in the restrictive restraint group had about 6.7 days alive without delirium or coma, compared with roughly 6.3 days in the liberal restraint group. The difference was not statistically significant. Other clinically important outcomes were also similar between groups. Self-extubation occurred in approximately 9% of patients receiving the restrictive strategy, and about 8% of those receiving routine restraints. Mortality at 90 days was also comparable. These findings challenge a long-standing assumption in ICU care. Restraints are often justified as necessary to prevent device removal or other safety events. But in this trial, using fewer restraints did not increase self-extubation rates. At the same time, reducing restraints did not significantly decrease delirium or coma either. The most practical interpretation is that routine prophylactic restraint of all ventilated patients may not be necessary. Instead, a selective approach in which restraints are used only when severe agitation occurs appears to be safe. This aligns with broader ICU practices that emphasize lighter sedation, early mobilization, and more patient-centered care. Let's close with a concept that has moved to the center of how we understand COPD: small airway disease. When most clinicians think about COPD, the numbers that usually come to mind are spirometry values, FEV1, the FEV1 to FVC ratio, and GOLD staging. These measurements are how we diagnose airflow obstruction and classify disease severity. But those numbers mainly reflect what is happening in the larger airways. COPD, however, does not begin there. It begins in the small airways. These are bronchioles with an internal diameter of less than about 2 millimeters, and they are now recognized as the primary site of airflow limitation and disease progression in COPD. These airways are sometimes called the silent zone of the lung, and that term reflects an important physiologic reality. The lung contains thousands of these small bronchioles arranged in parallel. Each airway contributes only a tiny fraction to total airway resistance. Because of that arrangement, the lung can lose a substantial number of small airways before global resistance increases enough to affect spirometry. In other words, a significant amount of disease can accumulate before FEV1 begins to fall. This helps explain a clinical scenario many pulmonologists encounter. A patient who smokes presents with cough, dyspnea, or reduced exercise tolerance, but spirometry still appears normal. In many of these patients, the earliest pathology is occurring in the distal airway tree. So, what actually happens in the small airways during the development of COPD? The process usually begins with chronic exposure to inhaled irritants, most commonly cigarette smoke. This exposure triggers inflammation in the bronchiolar walls. Over time, that inflammation leads to structural remodeling. The airway wall thickens, mucus production increases. Fibrosis narrows the airway lumen. At the same time, destruction of surrounding lung tissue reduces the elastic forces that normally keep these airways open. During expiration, especially forced expiration, these weakened bronchioles collapse prematurely. That premature closure leads to air trapping, increasing residual volume and creating uneven ventilation across the lung. As disease progresses, these processes contribute to the development of emphysema and worsening airflow limitation. One of the key challenges in clinical practice is that spirometry is not very sensitive to early disease in this region of the lung. Measurements like FEV1 primarily reflect airflow through larger conducting airways. By the time those values decline, a substantial portion of the distal airway network may already be damaged. Historically, clinicians attempted to use mid-expiratory flow rates, particularly FEF 25 to 75, as markers of small airway disease. The idea made physiologic sense, but in practice, these measurements are highly variable and poorly reproducible. Because of that, they have limited usefulness in routine clinical care. This limitation has led to increasing interest in other physiologic techniques capable of detecting distal airway abnormalities earlier. One of the most promising is oscillometry. Oscillometry measures lung mechanics during quiet breathing, rather than during forced expiratory maneuvers. The device sends small pressure oscillations into the airway while the patient breathes normally. By analyzing how airflow responds at different frequencies, the system can estimate airway resistance in different regions of the lung. Two measurements are particularly important, R5 and R20. R5 represents airway resistance measured at a low frequency, 5 Hz. Low-frequency oscillations penetrate deeply into the lung and therefore reflect resistance across the entire airway tree, including both central and peripheral airways. R20, in contrast, represents resistance measured at a higher frequency, 20 Hz. These higher frequency oscillations mainly reflect resistance in the larger central airways. The key insight comes from comparing these two values. If obstruction is primarily in the large airways, both R5 and R20 increase together. But when the obstruction is mainly in the small airways, total resistance measured by R5 increases, while R20 remains relatively stable. The difference between the two values, R5 minus R20, therefore becomes a marker of peripheral airway resistance. A larger difference suggests that the distal airway compartment is contributing disproportionately to airflow limitation. The important point is that oscillometry can detect abnormalities even when spirometry is still normal. This means that in smokers or symptomatic patients with preserved spirometry, oscillometry may reveal physiologic changes that reflect early COPD. And that brings us to the clinical takeaway. COPD is fundamentally a disease of the small airways, and much of the early pathology occurs before traditional spirometry detects airflow limitation. As techniques like oscillometry become more widely available, they may allow clinicians to identify airway dysfunction earlier and better understand the mechanisms driving symptoms and disease progression. For pulmonologists, this represents a shift in perspective. Instead of viewing COPD only as a disease defined by spirometry, we increasingly recognize it as a disease that begins in the distal airway compartment, long before spirometry becomes abnormal. And understanding that early phase may ultimately change how we diagnose and manage COPD in the future. And that wraps up this week's update in pulmonary and critical care medicine. This week, we reviewed the SOHO trial, which compared high-flow nasal cannula to standard oxygen therapy in acute hypoxemic respiratory failure and found no mortality benefit, though there may be a modest reduction in intubation. We also looked at the JAMA ICU restraint trial, which reminds us that reducing restraint use alone does not necessarily translate into improvements in delirium-free days. And finally, we discussed why the small airways are central to COPD physiology and how measures such as R5 and R20 can reveal airway dysfunction long before traditional spirometry changes appear. If you found this helpful, consider sharing the episode with a colleague or trainee. And if you're interested in more concise reviews of new pulmonary and critical care research, you may also enjoy our previous episode on pleural drainage strategies and ICU sepsis trials, which you can find linked on your screen now. This has been This Week in Pulmonary and Critical Care Medicine. I'll see you next week.